Very good afternoon, everybody. I think it's a good after a good FACO session. Glaucoma is always is very difficult, and also most of you don't like also. That is the problem. So I think I will try to make it simply. So why we talk about glaucoma? Because one of the leading cause for irreversible blindness in the world. Cataract is always known as a reversible cause of blindness, and glaucoma is one of the leading cause for blindness in the worldwide. So, diagnosis of glaucoma is usually made clinically. You no need to have a fancy machines like OCT angio or OCT even. If you do a good clinical evaluation, 99% of the glaucoma case you can direct by your clinical evaluation only. So for that you require a comprehensive eye examination. Of course you need a slit lamp tonometry and gonioscopy and dilated stereoscope evaluation of the optic disc and the retina. Automated perimetry, of course, to confirm your finding, especially in a case of glaucoma suspect. In an obvious case, you can diagnose this glaucoma, but you cannot grade a glaucoma without a visual field evaluation. So, if you are diagnosed in a clear-cut case, that is a moderate to severe case, even you can diagnose the glaucoma without the automated perimetry. Imaging techniques are not essential for a diagnosis, but have a role in play in the follow-up basically. So, usually the patient does not present with a diagnosis of glaucoma for evaluation because majority of the primary open angle glaucoma as well as the primary angle closure glaucoma except the acute part is asymptomatic. So, your responsibility to rule out the potentially serious ocular pathology like glaucoma. So, usually asymptomatic till the last stage at which the prognosis is poor. That is the worst situation. The asymptomatic disease, once it becomes symptomatic, that stage the disease is already in an end stage and the prognosis is also poor. So at advanced stage the diagnosis is a straightforward case. So best to detect the disease at a stage where the diagnosis is easy, possible, and intervention can alter the course of the disease to change the progression. That means early detection is the crucial for glaucoma management. So as a part of workup, you need to take a thorough detailed history, examination like vision acuity, refraction, external examination, pupillary evaluation, slit lamp microscopy, IOP, gonioscopy and dilated fundus evaluation, then perimetry and imaging. So history, POIG and PSCD are usually asymptomatic. A history of frequent change in the reading glass may be suspicious. My examiner asked the question for first time during my exam. First question was, what was the early signs, what was the significance of early presbyopia? So that can be one of the leading clue for a early POIG. So myopes are high risk for POIG and hypermetropes are high risk for PSCD, that you know. Family history, of course, relevant for glaucoma development, that is 8-fold chance for glaucoma. So a history should be directed, like it should be just a glare or photophobia because the vision acuity often normal. Sometimes the patient may just complain of the decrease in the contrast sensitivity, maybe in the form of glare. Frequent glare at the evening time may be due to an evidence of intermittent angle closure, or just for decrease in the contrast sensitivity may be the beginning of the glaucoma, and of course the visual impairment in the later stage. Difficulty for driving. Patient may say you like that, now I am usually have a good driving, good sense of driving. Now I have to put frequent sudden braking because the periphery has losing the vision. The object he cannot judge from the sideways. Frequent changes in the glass and prolonged medication. Of course, you have to ask in the detailed history of the glaucoma. Any kind of trauma, that trauma might be in 50 years back, past ocular surgery, uveitis, sleep apnea, and severe blood loss, any surgery, intracranial disease, systemic disease, and as well as the systemic medication, which may impact the glaucoma management. So examination is a comprehensive eye evaluation, not judge for the glaucoma. The patient you came for vision only, he is not bothered if it is glaucoma or retinal pathology. Patient want vision at the end of the day. So you should do a comprehensive evaluation. Start from the torchlight evaluation. So start with a torchlight evaluation. As you know, visual axis, the head posture and everything as do a routine evaluation. Then the vision acuity and the refraction. Then just to do an anterior segment evaluation, you can do before the IOP. The just appearance of the patient. The first picture, just see the pinkish discoloration of the entire face and the congestion of the conjunctiva. That's suggestive of a port wine spot appearance, that is Sturge-Weber syndrome. Just seeing the appearance to the patient, you can diagnose the disease. The second photo, there is dilated episcleral vein. This also suggestive of high episcleral venous pressure related glaucoma. In the third picture, this stare looking eye. This is signs of thyroid eye diseases. Thyroid eye disease also can have open angle glaucoma. And of course, the last photo, this angle closure, the congested eye with shallow anterior chamber. The congestion itself says some clue about the glaucoma. So ocular mobility. The first picture, always all the movement has restricted. The lower picture, the inferior, there is restriction of the superior movement of the left eye. The eye is moving downward only. That means some pathology in the muscles. The muscle pathology can lead to a differential IOP. The patient will try to keep the primary position because of some tightness in the lower part. The patient will of course keep the eye to keep the primary position, and that point of time this patient had basically an inferior rectus cysticercosis. Always the IOP was like 50-60 millimeter of mercury. Somebody have tried every kind of medication, including mannitol and everything. The pressure won't respond anything. Ultimately respond for just an albendazole tablet. So the position of the external appearance of the eye is also important for glaucoma diagnosis. Then examination of pupil, I already mentioned, you can do with torchlight evaluation. RAPD is an important sign to prognosticate the disease. And of course the loss of pupillary rough, that could be the earliest sign of an intermittent acute angle closure attack, or it could be an early sign of pseudoexfoliation syndrome. Then as you know, the von Herrick grading, you have to see the extreme periphery of the cornea with 45 to 60 degree angulation of the slit lamp. Then they grade the gap between the corneal shadow and the iris shadow, that is the thickness. That's the grade 1, grade 2, grade 3 and grade 4. Anything less than grade 1 is like 1.4 of the corneal thickness, that is angle closure. Slit lamp evaluation, I said you can get lot of finding. The first picture here is the pigment dusting on the endothelium, that suggests a pigment dusting, that is the pigment dispersion syndrome. The second picture, there is bronze beaten appearance, which suggestive of you should a good high magnification evaluation. You just diagnose is an iridocorneal endothelial syndrome, just seeing the slit lamp evaluation. Of course, this is the stellate capi. And here is the pseudoexfoliation. There is moth-eaten pattern of the pupillary border, which suggests again the pseudoexfoliation. This is the sunset glow and the posterior synechia, which suggests of an uveitic glaucoma. And of course, post-PK. This is the hazy cornea with mature cataract sunken nucleus, which deep AC suggestive of phacolytic glaucoma. This is the flat AC like and phacomorphic glaucoma. This picture also you can have like lot of iris nodule ectropion uvea. This is suggestive of a Cogan-Reese syndrome, and again this is an essential iris atrophy, and this is the glaucoma flecken. There is a necrosis of the anterior capsular lens, which suggestive of acute angle closure attack. So these kind of all information you can get just doing a slit lamp evaluation. Then of course then another part is the IOP. The Goldman applanation tonometer is the standard of choice and the gold standard. The same principle is applied in a Perkins patient, in children, or if the patient can't sit on the slit lamp. No excuse for a GAT for a glaucoma diagnosis and the follow-up. So technique, as you know, anesthetize with proparacaine, stain with fluorescent strip, no disinfectant residue left of the tonometer tip, and cobalt blue filter, that is the blue filter available on the slit lamp, should be used with a diffuse illumination, and the prisms are adjusted so that these two mirrors just meet inside, and reading should be multiplied by 10. That means that there is 1 millimeter reading, that means 1 into 10, this is equal to 10 millimeter of mercury. So patient factor, that is the technique. Patient should be straightforward with for a distant target. Patient should not be accommodated, that can have falsely high IOP, and the head should be leveled, and squeezing of the eye or upward movement can increase the high IOP. Physician, rest the index finger and the superior orbital rim, don't squeeze the eye, and repeated measurement can falsely lower the IOP. So this is the various type of mirrors you can get. The A should be the ideal one. The B is overestimation. There is this second one is due to astigmatism. This is the underestimation. Thick, high staining or thick mirrors, very thin mirrors. This is asymmetrically placed prism. So this should not be happening. The first one should be the ideal mirrors for a Goldman applanation tonometry. The source of error: thin cornea have underestimation. Corneal edema, spongy corneal edema can have underestimation. High corneal astigmatism, more than 3 diopter with the rule, can have an underestimation of IOP, whereas the high corneal astigmatism, more than 3 diameter of astigmatism against the rule, can have high overestimation of the IOP. So for a thick CCT, there is no clear-cut formula you can correlate CCT with IOP. You can say if there is a high increased CCT, the IOP will be falsely high. So for ideal, there is the 520 to 530, 550 is usually the normal range of central corneal thickness. For American Academy, it is mentioned that for every 10 micron increase in the CCT, you can adjust like 0.7 millimeter change in the IOP. That is just this, there is no formula at all. So if the IOP is normal or low, you should try to take a multiple reading at different time in your clinic, or do a diurnal variation, because the IOP have diurnal effect also. It can be very high at the morning, early morning, maybe normal in your clinical time also. So a normal tension glaucoma in your clinic may be a primary open angle glaucoma in reality. So gonioscopy must be performed. POH is often a diagnosis of exclusion. Angle closure burden of in our country is so high, so everyone must learn glaucoma, gonioscopy, and it's need practice. Do gonioscopy, you will get good different type of findings. So these are various gonioscopy. This is our Goldman mirrors. This is a kind of a direct gonioscope you can use in the OR or in pediatric cases. These are the Goldman 2 mirror. These are various kind of gonioscopic available. This is the normal gonioscopic finding. The first one is the Shelby's line, then the non-pigmented trabecular meshwork, then the pigmented trabecular meshwork. The red line shows the scleral spur, and the grayish white part is the ciliary body band. The second picture, there is a overexposure, over the bright light causes an open angle. If you reduce the light, it becomes a closed angle. So an adequate condition include dim light, room light illumination, minimum intensity on the slit lamp, and a low slit height. So that is minimum illumination, dark room should be preferred, because the first example, this is the second picture, there is open angle. Once you reduce the illumination, the angle become closed. And angle closures are classified usually by ISGO. You can be like PSCS because of just have a 270 degree oppositional angle, then PSC and PSEG later on. So you got a lot of finding in the gonioscopy. First picture, you get very thick, highly pigmented trabecular meshwork with symbiosis line which suggestive of pigment dispersion syndrome. Whereas in this picture, the line is just a broken line, patchy and pigmentation anterior to the Shalby's line, suggestive of pseudo-exfoliation syndrome. Here you can see the blood in the Schlemm's canal, and this is suggestive of some, and also the neovascularization of the angle, suggestive of neovascularization glaucoma. Here you could see wide ciliary body band with some scarring in the slit-like opening, which suggestive of cyclodialis cleft post-trauma, and there is the angle recession, this wide ciliary band. And this is of course the peripheral anterior synechia. Next part is the optic disc evaluation. The topic per se require a half day talk. So I just simplify. Start with the size of the optic disc, then the size, size, shape of the optic disc, whether it is horizontally placed or vertically placed. Then examine the cup disc ratio, whether the cup placed centrally or the cup placed eccentrically. For a centrally placed cup, 0.5 to 0.7 is normal. For even an eccentrically placed, 0.34 to 0.4 cup may be significant. So the position of the cup, then this is your neuroretinal rim, that is the area between the margin of the cup and the scleral rim. This is the neuroretinal rim, and the should have then the peripapillary area. Is there is any kind of peripapillary atrophy? Here is the retinal nerve fiber layer analysis on clinical evaluation. Here you could see there is darkening of this area as compared. This is the normal looking retinal nerve fiber, bright looking, whereas this area there is a dark shadow, wedge shaped shadow, which correspond to thinning of this neuroretinal rim. That means there is loss of RNFL. So should have disc hemorrhage. This is the superior thinning. This is some kind of an abnormal disc due to high myopia as well as the glaucomatous optic atrophy. This is also like a severe diseases because superior and inferior thinning. Just have some kind of nasal rim is remaining for these patients. Should not stop the glaucoma evaluation without any dilatation. Once you do gonioscopy, should dilate, do entire fundus evaluation, because sometimes any macular pathology may mimic some kind of cupping or disc pallor. So should have an entire macular evaluation. So imaging and visual, I don't cover just one slide each. Last talk during one question has asked about the optic disc evaluation. There is the first thing is the signal strength. One person asked that question. Signal strength any more than 6 or better indicate a good quality scan. If anything less than 6, you have to repeat. Then for a systemic evaluation, you have to have 9 zones, and we can elaborately discuss on some other different classes or some later on. Visual field also for time seeking, you have to do in a 10 zones from the patient data, reliability indices, the grayscales, and retinal sensitivity, grayscale, and the pattern deviation, the numerical plot, and the entire the graph, and the glaucoma hemifield test. I am going to describe the detailed because of the lack of time. And this is this kind of patterns you can get a inferior arcuate pattern, this visual field evaluation. So the diagnosis is glaucoma often clinically, and ophthalmologist should do a comprehensive workup. Perimetry should be obtained for all suspect case definitely, and imaging is not necessary for diagnosis, but of course is useful for monitoring the disease and escalating the treatment. Thank you, sir. Okay, I will continue the surgical part. Thank you, sir. So trabeculectomy may not be good. Patient good loving like a phaco emulsification. Phaco emulsification, I think everyone want to do, but trabeculectomy, a good trab means you did just a 25% job. Your job will start after you doing the trabeculectomy. So that is the importance of the trabeculectomy and the how to learn the trabeculectomy. So why is the till the now we have the only way of treating to reduce the IOP by means of medication, laser or any kind of surgery. So in advanced stage you definitely need a low target pressure and for preservation of the visual field, and because of the complaints and adherence also you need to perform a glaucoma surgery. So indications for glaucoma surgery: medically uncontrolled glaucoma, progressively deteriorating visual field even with medically controlled IOP, drug allergies, poorly compliance patients, and as a primary treatment in advanced disease requiring target IOP, because in that scenario you won't much time to start the medication, and of course the patient preference and economic consideration also. So what is the principles of trabeculectomy? You just bypass the diseased trabecular meshwork. So you have creating a different ostium or a artificial or a creating an ostium between the anterior chamber and subconjunctival space for bypassing the diseased trabeculectomy, trabecular meshwork. That is the gold standard procedure even in this MIGS era. So the step, first you have to give anesthesia. It could be general anesthesia if patient is a child, or in a patient is not cooperating, or most often preferred is the peribulbar and retrobulbar anesthesia. Don't add adrenaline, because these are patients have, if there is one insult of low perfusion to the optic nerve, then increase in the loss of visual field, the chance of severity will be increased. So avoid adrenaline, avoid excessive globe massage that we usually do for an ECC or SICS. So general anesthesia, don't put put minimum quantity of anesthesia. You need a good exposure for a trabeculectomy. With badly done anesthesia, definitely you will have a bad outcome for trabeculectomy. So the stuff from the anesthesia itself is very important for a trabeculectomy. So the exposure, you can use either a 6-0 Vicryl or a 5-0 Dacron suture. For usually we do a clear corneal suture for 6-0 Vicryl, especially if patient is post LASIK. In that scenario you can do a superior rectus bridling. So for normal cases you do easiest way is the clear corneal traction sutures. Just 1 millimeter from the limbus, 4 to 5 millimeter width, and 3/4 of the corneal depth. The exposure is then. Now the conjunctival flap preparation. So fornix based or limbal based flap, you can prefer. This is a fornix based flap. Fornix based means the base of the conjunctival flap is in the fornix. So just put a nick, then do an hydrodissection of the subtenon tissue, that will get a good exposure and minimal trauma. Superior quadrant is preferred, a 6 to 8 millimeter incision, and slide side cut so that we will get a good exposure. After then you do good subtenon dissection with your sclerocorneal scissor or a conjunctival scissor. After get an adequate dissection, do a light cautery. Light cautery means light. If you do excessive cautery, it will cause more ischemia. More ischemia means there's more vascularization postoperatively, more failure. And if you do excessive cautery, again, once you start the scleral flap, the flap will shrink. So light cautery to just arrest the bladers. This is the the size. Now this making scleral flap. You can make a triangular or rectangular flap. Triangular flap is easy. 4.2 to 4.5 into 4 is like 4.5 into 4.5. Rectangular means 3.5 to 4.5 millimeter. This is making a triangular flap. Measure with caliper. Then the side incision with side port or an 11 number surgical blade. 2 side incision. like this should be like 3.5 and this should be like 4.5. Then just lift the apex of the triangular incision. Then just try to lift. After lifting, use a crescent blade or a 15 number blade. Crescent blade is easy because that you can place very well parallel to the sclera. So lift and just dissect very gently. Yeah, very gently. So go like anteriorly, just short of the 1 millimeter short of the limbus. The side incision should not go till the limbus. Then once the dissection become near to the side incision, that's parallel to the side incision, go slightly more anteriorly into the clear cornea as we go during an SICS incision. So the anterior part should be like this. Yeah, this should be like a tunnel. Yes, that is it should be 50% depth, 1/3 to half of the scleral depth. This is making a quadrangular incision. This is a quadrangular incision. First make the posterior incision, then make the side incision. And what I do is, very easiest technique is, as all you are doing SICS, just do the posterior incision 3.5 millimeter from the limbus, then proceed with a crescent knife as we do a small incision cataract surgery. Go till the clear cornea, then just put the side incision after making the ender subscleral partial thickness scleral dissection. That is very easy actually. So for that, the crescent should be, the shadow of the crescent should be partially visible. If the shadow is not visible through this scleral flap, that means you are in the deeper plane. So change the plane. If shadow is very clearly visible, that means so anteriorly. So the part of the shadow should be slightly visible. So of course the anti-metabolite, that is the MMC, the sponge application of the MMC, that is the most way of doing an anti-metabolite. 1 millimeter cut scleral sponge soaked with mitomycin C. You should count the number of sponge you applied, otherwise sometimes you will get confused. Sometimes you can miss this sponge, that will be causes necrosis of the sclera. After giving thorough wash, after removing the sponge, put a clear paracentesis incision. Just press the posterior lip so that some of the aqueous should gush out, so that slow decompression of the anterior chamber should be ensured. Then just finally making this sclerostomy. So with a 15-degree knife or 11 number blade, how to enter? You should enter the junction between the clear cornea and the blue-gray zone. That I will show in another picture. Do enter, then with a crescent, there is Kelly sponge or a 15-degree knife. With a Kelly sponge, take a bite. This is like 0.5 to 1 millimeter sclerostomy should be made. 2 to 3 bite will be sufficient. Now you made this is the sclerostomy. After making sclerostomy, with a tooth forceps, gently pulled out the iris and cut with a Vanna scissors. Gently grip the iris, pull it and cut it. So this is the how to make. This is the just for a schematic representation. This is the junction between clear cornea and the blue-gray zone, and you may confuse with the the anatomy in the Qurana, so you will get confused in the Qurana. So this is the junction between the clear cornea and the blue-gray zone. This is the blue-gray zone basically. Here your Schlemm's canal will be this area. So start here making incision here so that your bite will contain this much area. So try to avoid posterior bite. If you do go more posteriorly, if you start from here, then take a bite for a scleral sponge, you will hit the ciliary body. So that can have a huge profuse bleeding. So even if you make a slightly anterior sclerostomy, nothing to be worried. Even is in a pure cornea, nothing to worry, you will get a good filtration. So try not to go posteriorly. So of course suturing, first you suture the apex with a 10 nylon, a tight suture as you usually do on a corneal wound, 3-1-1. Now the releasable sutures. So for a releasable sutures, you can use any kind of, you are comfortable where. Start from this area, go partial sclera, then come out through the partial cornea, come out, then start again from the cornea, partially come over the flap, then take this edge of the flap, pass through the scleral flap, then this normal sclera, then just do like a shoelace pattern. So for nasal flap suture, start from the temporal side, come towards the nasal area, then make the bite through the flap and the sclera, just 3 or 4 knot. Just make a shoelace pattern, so that at the end of the surgery you will have a loop on the cornea that can be pulled out post-operatively if your patient IOP is high. Of course, the last part of the slide, the presentation, is the closure of the conjunctiva. Is for a fornix-based trap, you need a tight closure. First, deepithelize the limbus, then take two wing sutures with a 10 nylon or a 8 vicryl. It should be tight actually. I am tightening the sutures. Then you can do 1 or 2 extra sutures on the these side margins, so that you will get a good watertight sutures. At the end of the surgery, there should have some kind of blood form. Not worry, you don't need to diffuse blood at the end of the surgery. So final picture should be a formed anterior chamber, no conjunctival retraction, and the ideal should be visible like this, initial post-op day like this, then you expect a good blood like this at the end of 3 months, but often you don't. And post-operatively you have to assess vision acuity, IOP, anterior chamber detail, and nature of the blood. Look for any choroidal or serous choroidal detachment or serous retinal detachment, and start steroid for at least 4 to 6 weeks, cycloplegic for 1 to 2 weeks, and antibiotic for 1 to 2 weeks. Monitor vision acuity, IOP, anterior chamber depth, nature of the blood, every follow-up visit. And in reality, most often you will get the blood like this. This is the complicated blood. I think Dr. Parul ma'am will discuss elaborately on this complication of the trabeculectomy. So you won't get a blood like this majority of the time. You will get a blood like this, and you have to know how to manage this kind of blood. I think madam will discuss that topic in a minute. Thank you.